Hi, I'm Dr. Sievers, professor of medicine, specialized in cardiology, vascular medicine, gender medicine, and also one of the board members of the German Society of Gender-Specific Medicine. Gender medicine is gaining more and more attention and importance in Germany, also in Europe. But the country where it's all coming from is the USA, and they have the most experience in gender medicine and also in setting up gender medicine programs. And so do you, Holly. So today I'm talking to Dr. Holly S.Andersen. Holly, it's great having you. Thank you so much for your time. Can you tell us a little bit about you, what you're doing, what your positions are, and what you're passionate about?
I am a cardiologist, an attending cardiologist at the New York Presbyterian Hospital. I'm also the Director of Education and Outreach for the Ronald O. Perelman Heart Institute at the New York Presbyterian Hospital, Weill, Cornell Medical Center. Very long title. And Ron Perelman, who gave us a very initial large gift to open up the Institute, was very interested in women's health and women's heart health. And that's one of the reasons why he chose us to give his very large donation.
Great. Yeah. So that's the difference between the US and Europe, especially in Germany, because we do not have huge donations where we can set up programs and work with. So, but this is very much appreciated. Sure. So heart disease is the woman's #1 killer in the US and worldwide, and actually causing more death than all cancers combined. So this is something we need to talk about and address, because it is not addressed too much. So Holly, you are passionate about women's cardiovascular health. Please tell us, where's your strong interest for women's heart disease coming from?
Well, I think the first time that I got very interested in it, I was in my medicine training, and I learned for the first time that heart disease was the #1 killer of women. And this was when I was studying for the boards in internal medicine. So I went through all of my training, and I just realized that fact very late in my training, and I was kind of shocked by it. And then I became a cardiology fellow. This was 1993, 94, 95. Very few people were talking about cardiovascular disease in women then. There were at the national conferences, but very few people were talking about it. So I started looking at the large trials that were coming out at the time on statins and heart failure, and looking at the data by gender, which often wasn't reported. You had to really go look for it. And then when you looked at the data by gender and you looked at the results, they were very disparate. They were very different between men and women, and no one was talking about that. So I kind of kept researching this and connecting the dots and making my notes. And you know, in cardiology, the one that wins the argument in conferences is the ones that has the most data, pretty much. And my first talk on cardiovascular disease in women was at a tri-state cardiothoracic surgery conference, and I was the youngest faculty member there, and I was the only woman. And they asked me to give a talk about the cost effectiveness of heart disease women. I'm like, can I just give a talk about heart disease women, not the cost of it? They're like, sure. And I knew they were kind of like not very interested, but I knew I was going to put up a slide that they didn't know. And that was, of the 3 major trials from which we derived all our information on who should receive bypass surgery, of the more than 2,300 individuals in these 3 trials, 72 were women. And I knew they didn't know that, and they didn't. So I got their attention then, and I've been talking about it ever since. So 3 decades.
Yeah, well done. So yeah, thank you so much for letting us all these insights know. So you at your institution also, you're running a women's heart program, of course. So why is it so important to actually have a women's heart program?
You know, our women's heart program really permeates everything through the Ronald Perelman Heart Institute. We discuss and focus on it in our research and our clinical work, and also in our teaching of medical students, residents, fellows, and other colleagues in other professions. So we do not see women in a separate setting. We really put the focus on gender differences in cardiovascular disease in everything we do at the Perelman Heart Institute, and also clearly do a lot of public outreach as well.
But this means that all your colleagues are also trained in gender-specific medicine and are aware of all this?
Well, in cardiology, they definitely are, without question.
Okay.
And we also have hosted important conferences for colleagues. So we brought major heads of research of cardiovascular disease in women to our institution on an annual basis to give a symposium.
So do you have a dedicated outpatient clinic for women's heart disease?
No, we don't. We don't see women in a different setting. Again, it permeates everything we do. It's part of it, and we all see both men and women.
Okay, okay, good. So, as you know, women do not often talk about their diseases and are far less to call the emergency number, the 911 in the US. So, why do you think is that?
Yeah, we did, through the Women's Heart Alliance, we did research and found that only 23% of women could name another woman who had heart disease, and only 11% could name another woman who died of heart disease. Now, how is that possible when heart disease is the #1 cause of death for women in the United States and globally? And I think it's for two reasons. One, we don't talk about our heart disease, much in the way that women didn't talk about breast cancer in the 1970s and 1980s. We don't talk about it because we think we're going to be judged as somebody perhaps who didn't take care of themselves. And women just die of heart disease, and people attribute it to something else. They can die in the middle of the night and people think, oh, well, they must have been sick. They don't recognize it. You can come into the hospital, have a heart attack, have a bypass surgery, and go home and not tell anybody about it, right? But now pretty much everybody with breast cancer talks about it. And that community is much further along and empowered than we are, unfortunately.
Yeah, that is.
So we're working on that.
Yeah, you're working with the Heart Alliance. Yeah, I researched a little bit. That's a great story behind it. But you are also a director of education and outreach. So one of your duties and passion is also to teach colleagues and doctors. So is gender-specific medicine a solid part of the medical education in your institution? I think it is. But in most institutions in Europe, it doesn't play a big role in the medical school and also not in the hospitals. So how do you implement this gender-specific education in the clinical practice?
Yeah, I always said if I had even one class on gender-specific medicine in my training, I think I would have looked at data, I would have looked at research, I would have looked at patients differently. And so we are working on that at a national level, and to get it into national educational programs, you actually have to write board questions on it. Then everybody will teach it. So that's a national effort. In our Weill Cornell Medical College, we actually produced a video educating medical students on cardiovascular, really quite comprehensive differences in gender medicine in cardiovascular disease. That's excellent. And we've made that available to other institutions as well. I think that depending on, the disease series, people do different things. But most importantly, we want gender medicine not to be what has been termed bikini medicine, not just about reproductive medicine and about breast medicine. It's so much more than that. We are different physiologically, we are different genetically, and we are different pathophysiologically. And we need to know that.
Yeah, that's so true. So, but there's a lot of, in Germany, so that is a big issue because all the doctors are not trained in medical school and also not in the hospital. So we have really a lot to do. So, but you do not care only about the medical stuff and the doctors, but you also care about the general population, also those people without medical background. And as we know, the awareness and information of the general population about heart disease in women or health disease and their specific needs is still very little. So there is a big information gap actually that prevents women from getting the right care. And well, but there is not only women and men, but there is also different ethnicities, such as people of color. And we also know that people of color, for example, do have higher risk for cardiovascular diseases than white people. So that's why you care also about the personalized medicine. And I researched you did a very smart thing, and you invented heart smarts. So what is this about?
So I was asked to testify in the New York City Council on cardiovascular disease in women. And when I went to the only council members that were there when I testified were really mostly of underserved communities, the Black and Hispanic communities. And they talked all the time about how they went to Friday night fish fry at their church, and on Sunday after church they would have fried chicken. And I'm like, wow, if we could teach a whole culture like the importance of a good diet there, you know, we're not reaching that population in our lectures, in our dissemination of information. So we started out with a faith-based program where we actually wrote scripture into an NIH curriculum about preventive heart health. And we did a train the trainer program. And I have this wonderful woman running it, Dr. Nasa Lotetti. And we were in our 10th year. So when we started, the city had actually lost funding of a similar project. So we already had congregations that were really excited to do this. And what we did is it's a train the program where we had mostly pastors from 10 different congregations came to our hospital 10 weeks, a 10-week program to learn about heart health and preventive heart health. And then they went back and taught it to their congregations. And to date, as of our 10th year anniversary, we have taught programs in all 5 boroughs. We've trained 209 ambassadors, and we're still in touch with all of our ambassadors. We're a part of their community. They're a part of us. And that group has trained over 5,200 people in the same course. So, when COVID hit, we did a virtual programming, and we trained over 890 people about heart health through a virtual program. And we also went to a secular program, and we did a men's heart program, and we did a women's heart program. We did a plant-based program, and we have outcomes, amazing outcomes that show not only is their knowledge better, but their waistlines and blood pressure and sugars and lipid levels are better. So it's been incredibly effective program and recognized nationally by the NIH.
Yeah, that is such an important and really success story. So that you also have all these better outcomes because of all the information and the training and the ambassadors. So that is really something. And is it are you spreading it out to other to other nations or to other countries?
We have actually on our Zoom call, on our virtual, we had people from, we had international participants when we went virtual, which was great. Yeah, and that just has opened up avenues of being able to train others. I think you really need to have trust when you go into a community and you try to educate them. And I think that particularly the Black congregations already had a health ministry, like people who are retired nurses or doctors or somehow had some information in the health profession, already had a network trying to do some education. So we had a very motivated audience. And I think the difference also is that it is a faith-based program and not a faith-placed program. You don't go within your program and tell them, you have, it really incorporated scripture of people of faith, really took it that this is what we're supposed to do, is take care of our health and take care of our bodies.
Yeah, that's very nice. That's very important. So, Holly, what for you, like following also all this research work in gender medicine, what would be the most exciting recent research findings regarding women's health or gender medicine?
Well, I wish I could say the most, I think the most striking recent research was more positive, but you know, when we looked at awareness in this country about women, you know, awareness that women's heart disease is the #1 cause of death has actually decreased in the last decade. And it is the lowest among young women, and death rates due to heart disease is now increasing in this country after decades of decline. It's increasing in this country. It plateaued around 2000, and then it's been increasing, and it certainly increased after COVID. And it's increasing the fastest among young adults aged 29 to 45, and it's increasing the fastest among young women where awareness is the worst. So that data came out, and I think it's very disappointing to someone who has devoted so much time to try to raise awareness. But if we weren't doing the work we're doing, it would be worse.
Do you think that has mainly to do with COVID?
I think COVID definitely bumped up.
Yeah.
Well, unfortunately, it definitely bumped up cardiovascular disease during the pandemic. But the data that's come out from one of our VA trials that the burden of disease 1 year after surviving COVID is seriously increased in all aspects of cardiovascular disease: cardiac arrest, heart attack, stroke, congestive heart failure, atrial fibrillation, pulmonary emboli, all significantly increased 1 year after having COVID. This was all pre-vaccine data, but it's the economic and health burden of COVID is definitely going to impact our cardiovascular disease.
Yeah, that's dramatic. Yeah. So that will take some time to make up for this, right? Okay, Holly, thank you so much for sharing some insights, what you're doing, and all your very successful project. It was very interesting. And yeah, I learned a lot, and I researched regarding your work. And yeah, I was pretty impressed what you all did and what you are still doing.
Yeah, it's great to be able to be in this position and do it. And the one thing that's great about being a cardiologist is that so much of this disease is preventable. And if you can motivate people, if people knew they were at risk and knew that it was preventable, then we can do so much more. So it's always fun to talk to an audience about this. And I think when we do it, we save lives.
That's so true, and that's a nice closure sentence from you. So thank you so much, Holly, for taking the time. It was a pleasure meeting you.
My pleasure, and good luck in all your endeavors.
Thank you so much.